Hello, and welcome to ACR Journals on Air podcast. I'm your host, Vicky Shamagam. The manuscript we're going to be discussing today is deucravacitinib, a tyrosine kinase 2 inhibitor in systemic lupus erythematosus, a phase 2 randomized double-blind placebo-controlled trial published in Arthritis and Rheumatology and presented at one of the plenaries at ACR Convergence. There is a link to the manuscript in the show notes from today, as well as disclosures regarding this manuscript, since it is an industry-sponsored study. I'm pleased to be joined today by the first author of the manuscript, Professor Eric Morand from Monash University Department of Rheumatology. Professor Morand is the head of the School of Clinical Sciences at Monash Health, a clinical rheumatologist and founder of the Monash Lupus Clinic. Welcome to the show, Eric.
Hi, Vicky. It's a pleasure to join you.
So the manuscript we're going to be talking about today is obviously a very well-funded, large, multi-center clinical trial in lupus. But I wanted to start, if you don't mind, by just getting to know a little bit more about your journey in rheumatology, Eric, and your career in lupus. So could you start by telling our listeners why you spent your career studying lupus and what got you started, what keeps you going?
Yeah, thanks, Vicky. Actually, I haven't spent my whole career studying lupus. I actually started out as a basic scientist studying glucocorticoid biology, specifically glucocorticoid-induced proteins and their anti-inflammatory effects. And the first 10 years or so of my research career is actually studying rheumatoid arthritis. This was in the 90s, and I'm still working as a clinician. But as time went on and as rheumatoid arthritis treatments got better and better, patient outcomes were getting better and better. Every day working in the clinic, I was seeing the rheumatoid arthritis patients doing great and the lupus patients not doing great and not having any breakthroughs or new therapies. And as a person studying steroids, I continued to see all the harmful effects of steroids on my patients. And, we have patients who die, young women in their 30s who die in our hospital despite everything that we do. And it just impacts on me as a human, actually. And I came to a point where I felt like I needed to change the direction of my research into an area where the unmet need was greater. And that's why I started studying lupus.
Yeah, and you started off looking at sort of biologic molecular drivers of lupus, but then in more recent years have kind of pivoted more towards clinical outcomes. Was that something that happened organically as your career evolved, or was there some pivotal event that made you shift focus?
Well, we still run a lab, got a couple of significant lab programs that are not publishing that much at the moment because they're involved in some patenting and commercialization. But yeah, there was an event which shifted focus. So there was a regional discussion group about lupus in the Asia-Pacific region, which started to talk about the possibility of treat-to-target goals for lupus because this had become, as part of the standard of care for rheumatoid arthritis. And, we just looked around the room. It was a small group, and we realized that no one had done any clinical work on this endpoint in lupus, but it was all done in rheumatoid arthritis. And because I was a rheumatoid arthritis person who was starting to work on lupus, I just felt, and I still remember the day, I felt like, what's so hard about doing a treat-to-target endpoint like low disease activity in lupus? Why don't we just do that work?
I love it. Just do it.
Just do it. Literally, just do it. And I think coming from the side of the lupus space, informed by the RA world, and also coming as a basic scientist with a kind of, methodological head, just helped me, I think, in jumping into this new field. And I was probably quite naive, but yeah, literally just do it. And since then, we've just been doing it.
That's brilliant. And we're going to talk a little bit about the challenges that lupus clinical trials have had in a moment. But as we start to talk about this specific manuscript, I'm wondering, can you bring us up to speed with utilizing tyrosine kinase inhibitors in lupus? Help us understand why TYK2 specifically is thought to play a role in lupus and why this drug, which is a inhibitor of TYK2 and kind of locks it into an inactive state, why was this selected as a potential therapy for lupus?
So to make it easy for your listeners, they're all familiar with the use of JAK kinase inhibitors in the treatment of rheumatic disease. JAK kinases are receptor kinases that transduce the signal from a cytokine binding a receptor on the cell surface into signals in the cell that result in changes in gene transcription. And TYK2 is the fourth member of the JAK kinase family. It's not called JAK4, it's called TYK2, but basically that's the type of molecule that TYK2 is. And the reason that it's of interest in lupus is that it's different in significant ways to the other JAK kinases in terms of the cytokines that utilize TYK2. So TYK2 is activated importantly by type 1 interferon, and we all know now about the importance of type 1 interferon in lupus based on a couple of decades of basic science studies and the successful trials of anifrolumab. But deucravacitinib also blocks IL-12/23, and although the phase 3 trials of ustekinumab ended up negative, the phase 2 trials were quite interesting, and blocking IL-12/23 could be an additional area of benefit of deucravacitinib. And deucravacitinib also blocks the signaling of IL-10, and the role of IL-10 in lupus is unclear, but although it's thought of as anti-inflammatory in some contexts, there's some evidence that IL-10 is actually a bad guy in lupus and that blocking it could be advantageous. So all of these are reasons why deucravacitinib is interesting in lupus. And it's actually been studied extensively before in psoriasis, where it was recently approved by the FDA, and in psoriatic arthritis, where it's had a successful phase 2 trial, probably based on its IL-12/23 actions. And so with that background in knowing how to use it, how it works, what its safety is, it just seemed irresistible to study it in lupus because of the additive effect on interferon.
Yeah, and it's exciting actually to have another potential agent that's blocking this pathway, and reassuring, I think, that the FDA have already approved this agent in plaque psoriasis. So we have kind of an acceptable safety and tolerability profile in that population. Tell us now a little bit about the Paisley study or Paisley's studies that were designed specific for lupus to investigate efficacy and safety of deucravacitinib. These are phase 2 studies in lupus. They're randomized, placebo-controlled, double-blind studies, and we're comparing a number of different strengths of the medication versus placebo. And I think the strengths here were 3 milligrams twice a day, 6 milligrams twice a day, and 12 milligrams once a day against placebo. Tell us a little bit about the lupus patients enrolled and how you did the stratification to account for different levels of disease activity in lupus. What efforts were made to try and ensure the population really reflected the population we see with lupus?
Thanks. Designing and executing lupus trials, Vicky, is very challenging, as you know. There have been some high-profile failures in recent times. So careful design of an experiment in order to get a result is very important. Again, this brings me back to my basic science days, and I say to the students, you don't go in the lab unless you can design an experiment that you can get a result from. And lupus clinical trials are ideally designed as experiments from which you can get a result. Now, in an ideal world, they also directly inform on patients who might be treated in the future with such a compound. And so you're looking for this compromise between being informative about future clinical application, but also being an experimental design that will give you an answer. This study enrolled patients with active disease. Those are the patients who we would want to treat with a new agent. They had active disease despite already taking at least one background therapy, such as antimalarials, corticosteroids, or an immunosuppressant, or combinations. Active disease was defined by SLEDAI-2K of at least 6, requiring either skin, joint, or joint involvement, or both. The patients also had to have a systemic activity as manifest by a BILAG A or 2 BILAG B scores. And the combination of those two things ensures that you're getting patients who've got at least moderate active lupus. Patients had to be seropositive with a positive ANA, double-stranded DNA, or SM, and have stable background therapy. As is typical for these trials, patients had to not have severe organ-threatening disease, such as severe active lupus nephritis needing induction therapy or severe active CNS disease. And then, because geographic variation, ethnicity variation, and background disease activity and treatment can influence the response to therapy, patients were stratified, or recruitment was stratified, on the basis of geography, baseline SLEDAI-2K, and baseline corticosteroid dose. These are actually pretty standard for this type of phase 2 or 3 study design in general active SLE.
Yeah, and I feel like that is something where things have improved over the years just based on previous experience. There were also a couple of infection exclusions for this particular study. Is that right? You excluded people with recent influenza, herpes zoster, herpes simplex. Could you share with our audience why that was?
Yeah, look, type 1 interferon is very important for the host response to viral infection. That's the role of type 1 interferon in the immune system. And one way for your audience to think about why interferon is switched on is because interferon is switched on by viruses. A virus is just a little container of RNA or DNA that enters the cell. And when we have autoimmunity to RNA or DNA, as we do in lupus, then this can deliver packages of RNA or DNA to the cell. And the immune system simply responds to the presence of this RNA or DNA by activating interferon because it thinks there's a virus there. Now, the reason that this is important is understanding the biology of lupus, but also understanding the safety of medicines. Because if you block the pathways that are involved in those responses, there is a risk of increased viral infections. And so to try to do an experiment that you can interpret, you want to make sure that you're practicing safely in your research. And so if you have a medicine that has an at least theoretical risk of increased viral infections, you don't want to enroll a patient who has a current or recent viral infection.
Yeah, and so it's almost like you planned for everything with this study. You really thought everything through, except for a global pandemic, right?
Yeah.
Can you tell us a little bit about how the pandemic impacted the trial? You had patients on therapy when the pandemic hit, and then obviously you were still trying to enroll. Can you share with our listeners what happened and how were the study teams able to both keep the trial running and also, I think, incorporated some data in regards COVID impact on patients receiving therapy? Can you fill us in on that?
Yeah, well, you're right. It's been hugely challenging for every sector of the world and every person in the world. And running clinical trials is no exception, and running lupus clinical trials is no exception. And, emerging evidence from basic science studies during the pandemic suggested that host variation in type 1 interferon response could be a risk factor for severe COVID. So everybody doing trials of drugs in this pathway took this issue extremely seriously because the safety of patients is absolutely paramount. Once patients are enrolled in a trial, they and their investigators usually like to finish, especially if they're doing well. And so retaining patients who are already in the study is difficult, but quite doable. Recruiting patients into a study is really affected by the local, health operations and whether trials are allowed to continue to recruit. In our own area here in Melbourne, Australia, we had a pause where our hospital wouldn't let us enroll new patients into trials, basically to keep patients away from the hospital, which is where all the sick COVID patients were. So yeah, there were multiple impacts which varied around the world, but there was a very big team of amazing people running this trial, and everybody pulled together and got it done.
Yeah, I mean, it is really striking that they were able to still finish the study and finish the enrollment, even despite the pandemic. Let's jump back a little bit and talk a bit about the background therapies that you allowed, or I guess some were required background therapies in this study. Could you fill us in a bit more on that, and particularly the prednisone dosing and tapering that was permitted during the study?
So these are very important aspects of study design too. We think that we'll want to treat patients with a drug like this who are unresponsive to standard of care. At least in the first instance, I don't think we're in a space where treating somebody with a biological who has not yet tried an antimalarial is a likely outcome. So thinking of that future utility and also the way that regulators think, patients had to have active disease despite standard of care therapy. And so patients were on pretty typical lupus standard of care therapies. About 80% of patients were taking glucocorticoids. About half of the patients were taking at least 10 milligram of prednisolone or equivalent per day. About 90% of patients were taking antimalarials. That's a sign of good practice. And about 50 to 55% of patients were taking immunosuppression. Now, they all add up to over 100 because about 30 to 40% of patients were taking triple therapy, antimalarial, immunosuppressant, and glucocorticoid. And this is, again, fairly typical of lupus trials. If you're enrolling carefully patients with active disease despite standard of care, you would expect to see these background therapies.
And then you allowed some level of prednisone tapering during the study. Can you tell us about that?
Yeah, in fact, rather than allow, it was required. I've done a lot of work on steroids in the lab and also in clinical effects, and the evidence of harm of steroids in lupus patients is overwhelming. Everybody agrees that lowering the steroid dose is a desirable therapeutic goal, and it's reflected in the EULAR treatment guidelines for lupus. So the other advantage of lowering steroid in a clinical trial is it helps you see whether your drug is any good. If you can maintain or improve treatment response while tapering steroids, then you've got a medicine that works and delivers the outcomes that patients and physicians want. So there was a required steroid taper to 7.5 milligram per day or less between week 8 and 20. It was then kept stable to week 32, which is when the primary endpoint was. Then there was optional steroid taper from 32 to 40 and another 8-week stable dose before the secondary endpoints at week 48. And this is typical of recent lupus clinical trials that try to stringently manage downwards the steroid dose.
Okay, so we've done lots of build-up into the background of this study. Can you tell us what you found?
Well, so firstly, the patients were enrolled. I've talked about their background therapy, but they had active disease. The mean SLEDAI-2K was close to 11 across the population. The mean physician global assessment was about 1.8 out of 3, and 1.8 out of 3 on this PGA instrument is pretty high. So these were patients with a good going active lupus despite standard of care. The patients were randomized to 3 different doses of deucravacitinib, 3 milligram twice daily, 6 milligram twice daily, or 12 milligram once daily, or placebo. And there was about 90 patients in each treatment arm. And so the primary outcome measure was the SRI response at week 32. SRI response requires the SLEDAI-2K to fall by at least 4 points, in addition to which the no BILAG score can get worse, and the physician global assessment cannot get worse. And the combination of those things is designed to compensate for the deficiencies in each of those instruments by using them together. So the primary endpoint was met, and I love saying that phrase in response to a lupus trial because we don't get to do it that often. So the SRI response at week 32 in placebo patients was 34.4%. In 3 milligram twice daily deucravacitinib patients, it was 58.2%, which is a big delta. In 6 milligram twice daily, it was 49.5%. And those 2 doses were statistically significantly different to placebo. The 12 milligram once daily dose was 44.9%. And as a reminder, placebo was 34.4%. And this was also a good delta, but the study was not powered for statistical significance for the 12 milligram dose. And the p-value there was 0.078. It did not reach statistical significance. When looking at this endpoint, we also looked at time to attain first SR response, and this also favored deucravacitinib in the 3 milligram twice daily. The median time to attain SRI response was 85 days, less than 3 months, which is good, whereas in placebo it was 116 days, more like 4 months. So then what was important about this trial as well was the multiplicity adjusted key secondary outcome measures. And these were measured at week 48. And they included the SRI-4 done again at week 48, and that was statistically significant for the 3 milligram twice daily dose and for the 6 milligram twice daily dose. The BICLA response, which is a different composite measure of response where the primary driver of response capture is change in BILAG. And so it's similar to, but complementary and distinct to the SRI response. That was also statistically significantly in favor of deucravacitinib 3 milligram twice daily. And I measured dear to my heart because I was involved in generating it was the lupus low disease activity state, which requires you to have a low disease activity with SLEDAI of 4 or less, and low PGA, and low prednisolone. And that showed only 13% of placebo-treated patients, but 36% of deucravacitinib-treated patients with a 3 milligram twice daily dose, and that was a p-value of 0.0002. And the other, going on a bit here, the other key outcome measures were a change in skin score, measured with the CLASI 50, so 50% improvement in baseline CLASI, which is a measure of lupus activity. And that was highly significant in favor of deucravacitinib for all 3 doses, with 16.7% of placebo patients and 69.6% of deucravacitinib 3 milligram patients showing that response. And there were also significant changes in the final multiplicity-adjusted endpoint, which was change in joint count. So unusually for lupus trials, every measure worked and every measure showed a delta between placebo and active treatment. So yeah, it was very exciting when we first saw these results and saw it pan out across all the measures.
Yeah, I'm sure it was. I can imagine that the whole lupus community is thrilled actually after so many years of not having any studies really show benefit. So you had some exploratory endpoints too. Can you tell us a little bit about those, and particularly, I guess, the data on the interferon gene signature? Could you fill us in on that?
Yeah, sure. You can measure activity of the interferon system in a patient's peripheral blood by measuring genes that are induced by interferon, and that's called the interferon gene signature. It's measured using PCR tests usually, and that's measured at baseline in this trial, and then it was measured across the duration of the study. And it showed significant reductions in interferon gene signature for each dose of deucravacitinib, including the 3 milligram twice daily dose, the lowest dose, and all the way up to the highest dose. And there wasn't much difference in the level of suppression of interferon signature between the three doses. And we think that that might explain the apparent lack of dose response in the efficacy readouts for this study. As you've heard me say, many of the most significant effects were actually with the 3 milligram twice daily dose, although the 6 milligram twice daily dose had significant effects for some of the endpoints too. And this lack of a stepwise dose response may relate to the relatively flat and broadly equivalent suppression of the interferon signature that was seen. However, I will say that very extensive additional biomarker studies are ongoing, and we'll learn more about the association between these effects and efficacy and dose effects as those studies are analysed and published.
And I think that's going to be interesting to find, right? It does seem that you had a sweet spot, a sort of somewhere in the 3 milligram twice daily or the 6 milligram twice daily range seemed to be the likely dose you'll end up moving forward, I'm guessing.
Yeah, that's the thinking right now, because you would want to go forward with a dose that gave you the best effect in phase 2. The best evidence you've got for phase 3 is what did you find in phase 2. So, yeah.
And did you find any concerning adverse effects in these patients?
Yeah, well, as stated, safety is super important in general in care of patients, and certainly in a setting of an experiment like a clinical trial. And, certain safety events were monitored very carefully, including viral infections, as I've mentioned. But reassuringly, there was no major difference in the rate of adverse events or serious adverse events between placebo and the 3 doses of deucravacitinib. There were slightly more adverse events leading to treatment discontinuation in the deucravacitinib-treated patients, but the serious adverse events and overall rate of infections was not different between the placebo and the treatments. There was trends towards increases in viral upper respiratory tract infections. For example, deucravacitinib 3 milligram twice daily had 14% of patients had a viral respiratory tract infection versus 9% of placebo patients. There was also a trend towards urinary tract infection, and there was also a trend towards skin adverse reactions, which were mostly acneiform reactions.
And what about viral infections, particularly, I guess, COVID? What happened there?
No, importantly, we didn't see any major signals in systemic viral infections. Importantly, herpes zoster is, of special interest in the interferon space. We didn't see a signal for increased herpes zoster with this treatment. And that's different to the other JAK inhibitors that your community is more familiar with. And COVID-19 was found in 3% of patients on deucravacitinib 3 milligram and 3% of patients on placebo, with no meaningful difference in those rates.
And no sort of worsening levels of hospitalization, I guess you don't know. It's very small numbers, right?
So far as we know, no, there was no change in COVID infection outcomes. There were no deaths in the study.
And then I guess, is there any blood clotting concern or prothrombotic risk with this agent?
So, of course, there's concern because the JAK inhibitors we know have this association with cardiovascular and especially thrombotic events. But as I said at the start, TYK2 is different to the other JAK inhibitors, and it's not involved in hematological signaling. However, this was carefully monitored, and importantly, there were no major cardiovascular events or thromboembolic events in any treatment group in this study. And the study did not exclude patients with background antiphospholipid antibodies.
Yeah, which is great to know. And I feel like obviously something that will be continually watched, but is definitely reassuring to see at this stage. So there are a few other versions or iterations of the Paisley study ongoing. Would you mind giving us a bit of an overview of what those studies are looking at and the likely timeline for more data that might bring this therapy closer to the bedside for our patients?
Well, the first thing to say was that there was a lupus nephritis study that was initiated slightly after this general SLE study, and that study was not able to be completed, and that was largely due to the COVID-19 pandemic. That's been halted. Not because of any adverse effects, I want to stress, but just it was not able to be executed. So the program is moving into phase 3 trials to seek registration of deucravacitinib for the treatment of lupus. These would generally be 1-year duration trials, recruiting globally, with a design that's quite similar, actually, to the phase 2 study that we've been talking about today. Those studies are active and looking to recruit now. I need to say that it's very exciting that there's a lot of trials of lupus drugs happening in the world right now, and most trials are reporting slower than hoped for recruitment, partly because of the COVID-19 pandemic, which continues to impact on healthcare systems and investigators and patients, but also partly because of literally there being competition for lots of trials to do. So we think the data in this phase 2 trial are very exciting, and I'd love these phase 3 trials to recruit and report quickly so that we can learn more about this compound and if it's safe and effective so that we can get access to it for our patients. Especially seeing it's already approved for plaque psoriasis, there'll also be post-marketing safety observation data and so on, so that by the time these phase 3 trials are done, I think we'll know a lot about the drug, and that if it's shown to be effective and safe, then we'll have a lot more confidence.
And obviously this is an oral agent, which is, definitely a lot easier for many of our patients.
I need to say there's also several other companies that have got oral TYK2 inhibitors in development with earlier stage and phase 2 trials happening right now. So this target is one that we're going to hear a lot more about in the coming years.
Yeah, that's exciting. And I really appreciate you filling us in on that background and this study. I am looking forward to hearing more data coming out in the not too distant future. Thank you, Eric, for joining us today and giving us all your insights into the fields of lupus.
It's a pleasure, Vicky. Anytime. I look forward to talking to you in the future.
Great. Thank you also to our listeners for tuning in. This episode, I would like to also extend a heartfelt thank you to all the patients around the world who enroll in clinical trials. It takes a lot of effort to be in a clinical trial, and without the patient's faith in the scientific process, we would never be able to investigate new therapies with the rigor that is needed to advance through the approval process. Thank you. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRheum on social media, and please rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.